In this video, we will be talking about the last in the acid-base disorder topic, and this is the respiratory alkalosis. And in cases of the anxiety and in cases of the young patients who are into the stressful situation, we so oftenly receive these patients who ultimately are diagnosed with a condition known as the respiratory alkalosis. So let's talk about the respiratory alkalosis. As we have seen in the previous three videos on the acid-base disorder, that ultimately these diagnoses are made actually on the arterial blood gases, be it the alkalosis or acidosis, and be it the respiratory or metabolic. So the definition of the respiratory alkalosis again goes back to the ABGs. On the ABGs, the normal pH is 7.35 to 7.45, but when you see that the pH is more than 7.45, that means this is alkalosis. Then you will have to turn your attention to the partial pressure of arterial carbon dioxide. If it is less than 35 millimeter of the mercury, that means it is parallel with the pH, because when PaCO2 is less than 35, we call it the respiratory alkalosis, and pH already telling us that it is alkalosis. So these ABGs will be the respiratory alkalosis. Now let's see what is the relationship between the partial pressure of arterial carbon dioxide, pH, and acidosis or the hydrogen ion. We'll have to turn again our attention towards the Henderson-Hasselbalch equation. From our previous discussion, we have seen that pH is the inverse log of hydrogen ion, because in our routine labs we cannot measure the hydrogen ion directly. So and it is very easy to measure the pH. So pH is the inverse log, and we take the help from the measurement of the pH to know or ascertain the level of the hydrogen ion in the body. Now, from the Henderson-Hasselbalch equation, hydrogen ion is equal to 181 into partial pressure of carbon dioxide divided by bicarbonate. Now, from this equation, this is quite evident that when the partial pressure of carbon dioxide will go high, the hydrogen ion will go high, and ultimately the pH will come down. This is what we have seen in the respiratory acidosis. But inverse happens when partial pressure of carbon dioxide goes down, so goes down the hydrogen ion and this is what we call the alkalosis, but the pH will go high. So this is the relationship between the these three entities through the Henderson-Hasselbalch equation. And for our being at ease, we can write the Henderson-Hasselbalch equation with the help of the pH. pH is equal to 6.1 plus log into bicarbonate divided by 0.03 into partial pressure of carbon dioxide. So the relationship of the partial pressure of arterial carbon dioxide is direct with the hydrogen ion, but is inversely affecting the pH. So this is an important thing. Now there are certain clinical features with which these patients land in the emergency department. And what are those clinical features? Patient may feel the lightheadedness, patient may be confused, patient may be anxious. Why it is happening? Because of the decreased blood supply to the brain because of the respiratory alkalosis. In case of the respiratory alkalosis, there will be vasoconstriction, so the blood supply to the brain will be affected, cerebral perfusion pressure will be low, and the patient will be lightheaded and anxious. There can be perioral numbness. Patient may have the pins and needle sensation in the body, which we call the paresthesia, because in cases of the acute respiratory alkalosis, we see that there is increased binding of the calcium with the albumin, so there is decrease in the ionized calcium in the body, which causes the tetany. So these are the clinical features of the respiratory alkalosis. What are the causes of the respiratory alkalosis? These causes can be subdivided into the four main categories, and these four main categories will be the one which cause the hypoxia, the one which are related with the brain, and those which are related with the lungs, and those who are related with the mechanical ventilators. The one which are related with the hypoxia are decreased oxygen concentration or partial pressure of oxygen decreased in the blood. These causes are the decreased inspired oxygen tension. For example, if you are in a place where your body is receiving less FiO2 or fraction of inspired oxygen, it can also happen on high altitude, because there is decreased partial pressure of oxygen, and then you will have to take more number of the breath, or you will have to be tachypnic to gain more oxygen, and in that process you lose a lot of carbon dioxide. And it can be because of the severe anemia, because less red blood cells are available to carry the oxygen, so you need to take in more and more oxygen, and in that process you increase your minute ventilation or number of the volume of the air which you take in and out in 1 minute. In that process you lose a lot of carbon dioxide, which causes ultimately the respiratory alkalosis. Now there can be VQ mismatch or the ventilation and perfusion inequality. For example, it can happen where you have got the difference between how much air is going inside and how much blood is being recirculated to the lungs. So that inequality also results in respiratory alkalosis. There are certain CNS or the central nervous system disorder which ultimately result in tachypnea or hyperventilation. One can be that someone starts taking more number of the breaths voluntarily. And the other situation can be when someone has got the hysteric attack, patient is very anxious, and it can be the anxiety induced tachypnea. Then there are a lot of diseases which affect the brain, which will ultimately result in hyperventilation and respiratory alkalosis. There can be cerebrovascular accident, like it can be ischemic infarct, or it can be intracranial hemorrhage, which lead to the respiratory alkalosis through the hyperventilation. It can be brain infection like meningitis, encephalitis, can be a head trauma. It can be a brain tumor. All of these affect the respiratory center, and the brain tries to keep the partial pressure of carbon dioxide around 30, because that is how the brain is perfused in the best possible way. Because if the PCO2 is more than 40, there will be vasodilatation, there will be increased intracranial pressure. But if it is falling below 25, then there will be vasoconstriction. So the brain causes the lungs to take more and more breath to keep the partial pressure of carbon dioxide around 30 millimeter of mercury. The liver diseases like hepatitis, cirrhosis, they also develop tachypnea and respiratory alkalosis. It also happens in cases of the gram-negative septicemia. And if a patient is recovering from the metabolic acidosis, where the compensation was coming from the respiratory limb, the lungs were trying to get rid of the carbon dioxide to compensate for the metabolic acidosis, because we had seen that if one bicarbonate goes down to cause the problem, then 0.7 CO2, 1.2 CO2 should come down to compensate for it. But if the metabolic acidosis is corrected rapidly and carbon dioxide has gone out of the body, it will ultimately lead to this worsening of the respiratory alkalosis. Heat exposure again causes the hyperventilation and ultimately leads to respiratory alkalosis. There are so many other problems related with the lungs which result in the respiratory alkalosis. For example, if patient is pneumonic, patient has developed acute respiratory distress syndrome, patient has developed interstitial lung disease, and there is a pulmonary embolism. In all of these, what happens that there is a type 1 respiratory failure, where we see that partial pressure of oxygen falls less than either 60 millimeter of the mercury or 55 millimeter of the mercury. So in order to catch the air or to overcome the air hunger, body tries to take more and more breath. There is tachypnea, which ultimately leads to the decrease in the partial pressure of carbon dioxide, which we call the respiratory alkalosis. Sometimes we put the patient on the mechanical ventilator and we remove the carbon dioxide because patient had any of these problem, and we wanted to keep the patient's partial pressure of carbon dioxide around like 30 to 40. But somehow if we set the number of the breath, which is the respiratory rate, and the tidal volume, which is the volume of the air which goes in and out with each single breath, on a higher side, then it will over ventilate the patient, and the carbon dioxide can fall even less than like 20, less than 15. So this is very important. Be very careful whenever you are treating a patient on the mechanical ventilator. Avoid over ventilating the patient. Say if the patient had developed this problem of the respiratory alkalosis, where the pH is more than 7.45 and PCO2 is less than 35, now we had diagnosed from where comes the compensation for in these patients. Obviously, up till now, from our previous discussion, from the last 3 videos, we had seen that if the problem is with the respiratory, the compensation would come from the kidney side. And if the problem is from into the kidney or the bicarbonate, the compensation will come from the lung side or the respiratory limb. The only difference, major difference, is that lungs start to compensate for the primary metabolic problem immediately, but for the kidneys it takes them 2 to 5 days to complete the compensation as a result of the primary respiratory problem. So we divide the compensation for the respiratory problem into the acute and chronic respiratory alkalosis. So as a general rule, when 10 PCO2 or 10 carbon dioxide goes down to cause the acute respiratory alkalosis, then 2 bicarbonate should go down to compensate for this change in the carbon dioxide. But in case of the chronic respiratory alkalosis, because the kidney has been doing it for 2 to 3 days and now they are fully prepared to do it, so in cases of the chronic respiratory alkalosis, when 10 carbon dioxide goes down to cause the problem, then 5 bicarbonate should go down to compensate for this change. In the last video where we discussed the respiratory acidosis, perhaps I made a mistake. I would have written here 1. It is not 1. In case of the respiratory acidosis, when 10 PCO2 goes down to cause the problem, 1 bicarb in that case of respiratory acidosis will go high to compensate. And in case of chronic respiratory acidosis, when 10 partial pressure of carbon dioxide goes high to cause the problem, then 3 bicarb will go high to compensate for respiratory acidosis. But in case of the alkalosis, this is other way around. PCO2 comes down and bicarb should come down to compensate for it. In case of the acute, with each 10 decrease in the PCO2, 2 bicarb should come down to compensate for it. And in case of the chronic respiratory alkalosis, with each 10 fall in the partial pressure of carbon dioxide, 5 bicarbonate should come down to compensate. So if I mistakenly in the last video said that 1 by PCO2 comes down. This is not 1, this is 10 PCO2. But in case of the metabolic acidosis and alkalosis, yes, 1 bicarb goes high and comes down, and there is a change in the PCO2 which is 0.7 or 1.2 in either case. So this is the compensation of the respiratory alkalosis. And now once we have diagnosed that the case is of the respiratory alkalosis, then we are to go for the treatment of the respiratory alkalosis. First of all, we try to treat the primary cause. Whatever has caused the problem, we are to go after that cause. For example, if there is a CNS infection, for example, patient is suffering from the meningitis or encephalitis, and if we treat that primary reason, ultimately the respiratory alkalosis will settle down. Second are the kind of cases which are majority of these where the patient is very anxious. Then what should be our plan? In the past or the old days, we used to do that. We were to make the patient to breathe into the plastic papers, but there is a problem with it. It may increase the carbon dioxide in the body, or it may not increase the carbon dioxide in the body, but it will surely decrease the partial pressure of oxygen. So if it turns out that there was a hypoxemia already, and if we ask the patient or if we make the patient to breathe in and out in a plastic paper, it will aggravate the situation. So this has got a question mark that whether we should apply this formula on a patient of the respiratory alkalosis who is very anxious. So better option is to avoid this thing, but this is so oftenly done in the emergency department nowadays. In any patient who's anxious and who has developed respiratory alkalosis, and you think the patient is now confused, irritable, and patient is altered in sensorium, so you need to reassure the patient. You are to tell the patient that nothing bad is going to happen, so better you just calm down. But if it doesn't work, then you need to sedate the patient with the short-acting benzodiazepine like the midazolam. But in majority of the cases, if you reassure the patient, the respiratory alkalosis will settle down because the patient will start taking less number of the breaths. But also there is also a very important fact that if patient is tachypneic and there is respiratory alkalosis, then the respiratory center is also underdriven now. So ultimately the patient will start taking less number of the breath, and this is how the problem of the respiratory alkalosis will ultimately settle down because of the fatigue or exhaustion of the respiratory muscles. We need to avoid one very important thing, that because in cases of the chronic respiratory alkalosis, the kidneys have got rid of the bicarbonate to compensate for the chronic respiratory alkalosis. For example, if the 10 PCO2 goes down, 5 bicarbonate are thrown out of the body. But if we rapidly correct the respiratory alkalosis, especially the chronic respiratory alkalosis, it will end up with the metabolic acidosis, which can harm the patient. So we should avoid rapid correction or overcorrection of the respiratory alkalosis, especially those cases which are the chronic respiratory alkalosis. Thank you very much for watching the video, and if you like the video, please subscribe the channel and also press the bell icon.